Welcome everyone, my name is Madeline. I am a registered nurse working in the paediatric setting of a base hospital in the Central Queensland Hospital and Health Service area. Today I will be presenting, with permission, the case of a patient I cared for recently, presenting the patient history, presenting symptoms, and we will take a focus on the respiratory assessment of the paediatric client. The case I will be discussing today is that of a 14-year-old boy who had presented 3 days in a row to their local emergency department with the same symptoms: temperatures up to and above 40 degrees, a moist cough followed by difficulty breathing, increasing lethargy, as well as uncontrollable vomiting and diarrhea. On initial presentation, some routine bloods were taken, as well as blood cultures and a chest x-ray. There was nothing outstanding on the bloods or chest x-ray results, and blood cultures were pending. The child was assumed to be an early acute gastro, was sent home, advised to keep on top of Panadol, Nurofen and Gastrolite, and to follow up with their GP. On second presentation, the following day, they were told much the same thing. They were discharged home and they were to follow up with their GP. Then the next day, the patient presented again. Symptoms had worsened, the patient was showing clinical signs of dehydration, and the child was admitted to the paediatric ward for rehydration and investigation. The child was on day 3 of inpatient admission when I took over care one evening, and this will be the case I am presenting today. A day 8 pneumonia accompanied by influenza A and salmonella bacteremia. A brief background on the patient: the child was described as a normally fit and healthy young boy born at 38 and 4 via SVD with nil complications and an APGARs of 8 and 9. No known drug allergies. He had a wheat, milk and egg intolerance, wasn't on any regular medication besides the Panadol, Nurofen and Gastrolite in the week or so leading up to admission. Immunisations were up to date. He didn't smoke or drink. His mother reported that the flu had been going around at school. However, the patient was yet to receive his flu shot due to falling ill the week of vaccine release. The whole family had been unwell recently with flu-like symptoms, all of which had self-resolved besides the patient, who seemed to have got the worst out of everyone. This boy lived at home with his mum, dad and younger brother, had no pets in the house due to mum's allergies. He attended his local high school. His dad said he had a lot of friends, was well liked by everyone and was a high achiever academically and on the field with competitive football. The family were Christian in faith and said the patient enjoyed anything outdoors such as camping and fishing. There wasn't a great deal to report in family medical history either. No known respiratory conditions in either side of the family. Mother reported allergies to animals, mainly cats and dogs. The father was an advanced paramedic and mum was a school-based librarian, and the younger brother suffered eczema related to similar food intolerances to that of the patient. So initial observations when I have taken over care: his height is within the 97th percentile when plotted on a growth chart, and weight is within the 90th percentile. His mother reported that he had already lost approximately 4 to 5 kilos in the last week due to illness. So the patient is relatively healthy in those regards. However, my first set of observations show he is not so well. He has a temperature, his heart rate is up, his BP is on the lower side despite having IV therapy running. He's only saturating 92 to 94% with between 2 and 4 litres via nasal prongs. He's on continuous oximetry. There's a work of breathing evident from the door. The patient looks lethargic, pale and clammy. His parents are pointing out some new marks on his arm which indicate he's peripherally shut down. His cap refill is sluggish and greater than 2 seconds. The patient's not really able to converse due to lethargy, and his parents are doing a lot of the talking for him, including expressing their concerns for his condition and deterioration within the last 24 hours. The patient needs to be assessed in a warm, well-lit room, free of disruptions and in a position that they are comfortable, but you can also assess properly. In my case, the patient was sitting upright in bed with pillows to hold him in place. He was most comfortable there and I didn't need to move him a whole lot. Initially, I observed from the bedside without disrupting the patient, counting respiratory rate for a full minute. It's important to remember when assessing a paediatric patient that the parameters are going to be different and age should always be taken into consideration. This particular patient was sitting on the lower end but still within normal parameters for his age, with a respiratory rate ranging between 16 to 20. Next, we want to note the rate and rhythm of the breathing. I could see the patient was breathing quite shallow, with a short inspiration and extended expiration with an approximate ratio of 1 to 3, 1 to 2 being normal. His chest wasn't expanding a whole lot on either side with inspiration, and he was using accessory muscles to exhale. Now is a good time to ask any respiratory related questions. The patient had noted a dull pain on the inside of the left lung near the heart. This pain had initially been sharp when coughing, but had developed into almost constant dull pain that inhibited him from taking a deep breath. The patient stated he did not feel short of breath, but just like breathing was quite tiring. While the initial illness had accompanied a non-productive cough, a cough was no longer present. Extra information like this gives us more insight to what to listen out for when auscultating. Next, I auscultate using stethoscope. It's important to inform the patient and ask them to continue breathing normally. Auscultation should generally proceed from the apices to the bases, comparing opposite sides of the chest. With the stethoscope over each landmark, at least one cycle of inspiration and exhalation should be listened to. I started at the top of the lungs and worked my way down. The upper lobes had equal and normal sounding air entry, as did the right middle lobe. However, when I auscultated over the base of the upper left lobe, so sort of like the equivalent to the middle of the right, there was decreased air entry compared to the right side and a faint pleural rub, which became more evident when the patient was asked to take a deep breath. The base of the right lobe sounded normal, while the left lower lobe had essentially zero air entry. When palpating, warm hands are preferable. Starting at the top, we determine tracheal position, ruling out any deviations indicating pleural effusion or pneumothorax. And we're assessing thoracic symmetry. This can be determined by placing both hands around the patient from a posterior position with thumbs touching. As the patient inhales, the thumbs should separate the same distance away from each other before returning on exhalation. Palpation sequence is much the same as auscultation, noting any tenderness or bony deformities throughout the thorax. The palm of the hand should be used to assess skin temperature of the patient, noting any abnormalities such as clammy, hot or cold. Palpation is used to assess tactile fremitus, which is normal palpable vibrations. To assess, we place our hands over the patient's chest or back and ask them to repeatedly say the words 99. Fremitus is decreased in pleural effusion and pneumothorax and increased over regions of lung where sound transmission is increased by way of consolidation in cases such as pneumonia. Percussion seems to be the forgotten assessment technique, and to be honest, I didn't percuss this particular patient's chest, but we will touch on the topic as it is applicable and part of the full respiratory assessment. Percussion is a technique that involves placing the non-dominant hand with middle finger extended over the area of the chest being examined, using the middle finger of the dominant hand to tap on the distal knuckle of the finger resting on the chest wall. The sequence should be the same as that of auscultation and palpation, starting from the upper chest wall, moving side to side and comparing one side to the other. Normally the chest will have a resonant tone, while flat percussive, soft or high-pitched note can be indicative of a large pleural effusion. In cases of pneumonia, pulmonary edema, or pulmonary hemorrhage, a dull percussive note with medium intensity and pitch can be heard. As mentioned earlier, this patient had only had routine blood culture and chest x-ray upon presentation after approximately 3 days of being unwell. On admission, being day 5 of being unwell, a stool MCS had been collected and sent, and by the time I took over care, the blood culture and stool sample had both been reported on as salmonella bacteremia. However, these results had not been handed over. I noticed the patient had not had a flock swab done, which I promptly collected and sent to pathology. The results returned within my shift with influenza A detected. After discussion with the treating team, I strongly suggested a repeat chest x-ray, as it had been over a week since this initial imaging. The patient condition had significantly deteriorated, and with the frequency I was having the patient reviewed, it would have looked bad to not be investigating further. The team agreed to repeat a chest x-ray, which was also reported on within my shift, showing dense consolidation in the left lower lobe, indicating a well-developed pneumonia. Our facility practices based off Queensland Children's Hospital's guidelines and in consultation with infectious diseases, which indicated this patient required isolation, triple IV antibiotics to cover gram-positive and negative pathogens, IV hydration with normal saline and 5% glucose, and comfort measures such as antiemetic, antipyretic, and pain management. Clinical signs of deterioration were to be managed as they arose, such as oxygen therapy and escalation to higher care. My priorities as the nurse were maintaining stable airway breathing and circulation, close monitoring and documentation, assessing and reporting any clinical deterioration, and escalating as indicated. I prioritised patient comfort and parental support, which meant building rapport and maintaining open communication lines. I spent a lot of time educating the family as they had many questions about their son's condition, his test results, his care plan, and what might happen if his condition worsened throughout the night. While the patient remained relatively stable throughout my shift, he rapidly deteriorated on the night shift, was met-called, and admitted to ICU, where he remained on supports that our ward simply could not accommodate. As a nurse, you have a duty of care, which includes patient and family education and preventing spread of contaminants. Literature indicates that education and preventative measures such as basic hand hygiene, Seasonal flu vaccinations and early intervention are the keys to avoiding and reducing spread of influenza and subsequently pneumonia in children. During the 2019 flu season, there were just over 313,000 confirmed cases of influenza in Australia. 28.6% of people admitted to hospital with confirmed influenza were aged 15 years or younger. Of those, 8.5% were admitted to ICU, and unfortunately, a small portion resulted in death. Statistics later indicated that of all children confirmed with influenza in 2019, only 12% had received their seasonal flu vaccine. Influenza and pneumonia are among the leading causes of death among the Australian paediatric population outside the neonatal period, while ABS reports a direct increase in deaths among those who are reported to have both influenza and pneumonia. Statistics show that Australia's yearly vaccines have been very closely matched to the viruses that go around and therefore have shown to reduce the rate of spread if individuals are actually getting their flu shots, which are available to all individuals aged 6 months and above. They're generally free or at least subsidised. From here, we can reduce spread by maintaining personal hygiene, including frequent hand washing or use of alcohol sanitizers, avoiding those who are contaminated or isolating yourself if you are unwell, and seeking help early, either via GP with early symptoms or emergency department if unable to control symptoms or any emergent symptoms arise. This more or less summarises the education I provided to the family and, of course, answered questions to their satisfaction. The patient ended up spending 5 days admitted to ICU. He was stabilised on high-flow nasal prong, completed his intensive IVABs, overcame the pneumonia as reported by repeat chest x-ray. He was rehydrated, vomiting and diarrhoea had resolved. He was stepped back down to the peds ward for overnight observation. He'd remained afebrile for 48 hours, was tolerating diet and fluids with adequate output as reported on his fluid balance chart, and he was QTing a 0 within 24 hours prior to discharge. He was discharged home with his parents. They all vowed to get their yearly flu shots, stay on top of hand hygiene, and seek early intervention if unwell again. That concludes my presentation today. Thank you for your time, and I look forward to receiving your constructive feedback.